leukemia, when do we start therapy for these patients? Are there patients that we should just monitor?
And I think it's been reported that 30% of patients who have myelofibrosis may actually be asymptomatic, but ultimately everybody pretty much is going to develop symptoms either related to anemia, fatigue, or consequences of anemia, or symptoms related to splenomegaly and constitutional symptoms. So I think, to me, I try to understand the phenotype of the patient. Anemia obviously requires looking at the serum erythropoietin level, considering ESAs for someone who may have an endogenous level below 125. And then if there is no response after 8 to 12 weeks, then perhaps you move on to alternate agents such as immune modulators, danazol, and hopefully clinical trials afterwards if there's no response. But for those who have splenomegaly, constitutional, perhaps anemia mixed in with that, then I think JAK inhibitors represent a very reasonable frontline therapy, because this was driven from the data that came from the COMFORT trials. And when do I switch treatment? Well, I think there have been some descriptions of what is relapse or intolerance or resistance, if you will, to initial JAK inhibitor therapy such as Ruxolitinib. And then I think, obviously, Ruxolitinib being the only FDA-approved agent, I would consider putting those patients that have not responded or adequately responded onto clinical trials.
Okay. So, Ruben, clearly we've been talking about, other than transplant as the only curative option, palliation. So you have to have some way of measuring palliation, and this has been a real focus of your clinical investigation and research. Can you help us with how clinicians should be evaluating patients in terms of symptom burden and also then response to therapy?
Sure, sure. Well, first I would frame it that it's really about trying to alleviate the burden that patients with myelofibrosis face. You know, I'd say that palliation sometimes is used kind of incorrectly in almost kind of a pejorative way. You know, that it's really not having a real impact on the patient. You know, and myelofibrosis still, for many patients, from the time of diagnosis, they will have survivals that can range from a handful of years to many years. And that burden of disease, as we've been alluding to, is symptom burden, it's spleen-related difficulties, it's potential cytopenias, and there is that risk of progression and mortality. And that's a part where I think all the risks kind of come into that piece and the timing of transplant. But I think the medical therapy that we have, you know, clearly has a genuine impact, not only on the days of life lived, of which I think a patient who is benefiting from medical therapy with Ruxolitinib or another disease-related therapy, if it's efficacious, they are living longer. They may not be cured, but they are living longer. It is impacting the disease as well as the burden of the disease. Now, the burden of the disease is very important to both assess and then track, because it's helpful not only in terms of assessing the utilization of therapy, but really adjusting dose as well as determining whether the therapy is really efficacious. We've learned many things as we've kind of walked this arc and now have data in truly thousands of patients with myelofibrosis, and we have similar data that is comparable across pretty much most of the studies that now are done in myelofibrosis, which is very helpful. So there's different kind of portfolio of symptoms. Spleen-related symptoms that can be pain, discomfort, early satiety, and a range that are tied to that piece. There are clearly cytokine-driven symptoms that relate to cachexia, fatigue, pruritus, night sweats, etc. And then there are other symptoms that clearly may be associated with the most progressive end of the disease. Bone pain and fever, which is really the most uncommon. You know, if people were to boil it down and say, you know, what are some of the most impactful? I think one of the most impactful is really pathologic weight loss. You know, it is such an aberrant feature in our society. Nobody loses weight without trying. You know, I mean, we all know we all know this well. You know, so if patients are, that is a big red flag in my eyes that something is out of balance with the disease, and that's also something that we do note as also a pretty strong marker of response to JAK inhibition, that part really is both arrested or reversed. You know, so the takeaways I would have for people listening to this is one, it's very important, and it's not only very important in clinical trials. Now, I think it's really very important in terms of monitoring the disease. You know, these tools are now readily available. People should fill them out in the lobby, and you should sit as you examine the patient and their spleen size, as you're looking at their blood counts, you look at what their symptom profile is. Is that same, better, or worse? If it's still not where you would like it to be, is there an opportunity for increasing the dose of your JAK inhibition? Or if they have been stable for 2 years and now it's clearly worse, is that sign of a new comorbidity? Which I found that has sometimes been the case. Patients have developed a different disease, or they're now eligible for a clinical trial for progressive disease or things of that nature. So I think, one, medical therapy really is having an impact on these patients, and two, you really need to be monitoring that serially to adequately manage the patient.